an original MCM production.
And now we're ready to go forward. We have our moderator here, Ms. Millie Coby, and you will please take over.
Thank you, Chairman Stamper. We're here this morning to speak on a topic that I believe affects a lot of people that we know here in the city of Milwaukee and otherwise. Talk a little louder. We're here this morning to speak on a topic that I believe has affected someone that you know, or a coworker or a family member. And it's something that many times we were overlooked and we thought maybe it did not exist in our community, or either we turned a deaf ear to it. But as a result of the opioid crisis, we're saying today, wake up Milwaukee. Because when we see the number of deaths that are happening and the toll is rising in our city, we have to wake up Milwaukee. When we see how prescription drugs are being taken and people are not managed properly in a lot of cases, and it's taking their lives and affecting their families, and then we have generations and generations of addictions, we have to wake up Milwaukee. So this morning, I'm going to introduce our panelists. We have professionals in this area, and we want to thank them for taking time out of their busy schedule, because these aren't just participants on our panel that just sit around in the office and do nothing, but they're doing all that they can to fight and to help our communities, to make sure that people are aware and to make sure that they have the resources that they need to be properly managed. So we want to thank you for being here today. And at this time, I'm going to call Dr. Zelda Okia, forensic pathologist. She's the author of The Zombie Effect. She's going to come at this time and present. She'll introduce herself and present information to you. Let's receive her at this time. Thank you.
Thank you very much, and thank you for inviting me to come and speak with you. This is an honor, and I appreciate the opportunity to come and talk about this crisis that we're facing. When I first started working at Waukesha County, I'm a medical examiner, associate medical examiner there, in 2009. Most of the deaths were from heroin and other prescription drugs. When the officers would bring us a patient, they would say, "This looks like a heroin overdose, doc," and pretty much that's what we would find. Nowadays, they bring us heroin, and we are finding fentanyl, fentanyl analogs, phenylfentanyl, despropionyl phenylfentanyl, acetylfentanyl, acrylfentanyl. It's like being back in your high school chemistry class. And the problem is, this is a white powder. Kids don't know, or kids, we're saying, it used to be younger people that we were seeing on our table. Now it's running the whole age gamut. And people just don't know what they're taking. These look like white powders, so somebody could think they're taking cocaine, and there's fentanyl in there. So I think of it like Russian roulette. In Russian roulette, you've got the revolver, a 6-chamber revolver. Maybe there's one bullet in there. Now there's maybe 4 or 5 in a 6-chamber revolver. This is really dangerous stuff, and I feel for the people that do have this substance use disorder, addiction. These drugs are highly addictive, even more so now, and unfortunately, the more the addiction, the increased risk of death. So before, we would see mixed drugs with other prescription drugs like Valium or Xanax, benzodiazepines, which would increase the risk of overdose in heroin. But now the drugs are already being mixed. They're pre-mixed. So the risks are just so much higher, and that's why people are dying so much more. So whatever we can do. I'm an advocate for prevention. I'm an advocate for families. I wrote this book. I was really touched by the deaths that I saw in Waukesha County in particular, Zombie Effect, and I was just moved by the young people. A lot of them were young, and their bodies looked perfect on the table. They shouldn't have been dead. And they had their whole lives ahead of them. And that's why I wrote this book. And it's for families. I think families are our gatekeepers. They're the ones that notice when the kids start acting differently, when they're hanging out with a different group of friends, when their grades drop. And I just advocate for the parents to go into their kids' rooms. When I was training too, some of the stories we hear where the kid has, do not enter on the door, and the parents never enter the kid's bedroom, or the kids are living down in the basement, or adult children are living in the basement. Their parents never go down there. Go down there. Look at what your kids are doing. If you see things in there that don't make sense, that, why is your chore boy in the kid's bedroom? Why are there, corner side cuts of sandwich bags? Ask questions and engage your kids. That's my big advocacy now, is just parents engage your kids. And if you have any inkling your kid is using drugs, don't think it's just a phase. Don't think it's something that they're going to grow out of. These are desperate times, and they call for desperate measures. I've heard of parents taking the hinges off their kids' doors and saying, you cannot shut your door in this house. So this is your house, and take it back. So thank you very much.
Thank you, Dr. Okia. Next, we have Dr. Jillian Theobald, and she's an emergency medicine physician and medical toxicology at the Medical College of Wisconsin, the Wisconsin Poison Center, and she has a lot of experience in this area. She's very passionate about and very committed to helping people. And so at this time, we want to receive her as she comes with her introduction and information to us at this time. Thank you.
Hi. Good morning. So like she said, I'm an ER doctor at Frederick Hospital, and I also work at the Wisconsin Poison Center. So we take calls for the entire state of Wisconsin for any poisoning. So if any physician or even person at home wants to call us, we provide advice and care for them over the phone. The other thing that I'm also involved in is a project called Milwaukee COPE. It's the community opioid prevention effort. And what we've been doing is gathering data across Milwaukee County from the medical examiner, from the EMS, and then also from some of the social support services to kind of get a better handle on what's happening in our community. So we not only look at the deaths, but we look at the people that are overdosing as well. And we are trying to figure out how they touch the medical system so that we can get them care in the best way. And so what we've done is we've geocoded where these overdose deaths are happening. We've also geocoded where the overdoses are happening. And we've gotten data on the toxicology reports. So what drugs are these patients dying from? And then what mixes of the drugs are they finding in their system? So what we found is that very few cases are just heroin. So like Dr. Okia said, it's mostly mixes of drugs, so a lot of fentanyls, things that people don't know what they're having, but then also prescription drugs is what we've been seeing. And to speak to the African American community specifically, what we're seeing nationally is kind of mirrored in the Milwaukee County community, is that the steep rise in overdose deaths that we've seen is primarily in white people. And the reason for that is because of the prescription opioids. So they think that most people who are on heroin today, 80% started out on prescription opioids. If you look at over the course of, say, the last 10 years, the increases in overdose deaths, most of them primarily affect the white community. It's increased across the board. So African Americans, Hispanics, the other category for race, those have all increased. If you look at Milwaukee County specifically, in 2012, we had 33 overdose deaths from opioids in African Americans. In 2016, it was 56. But if you look at the bulk of all those overdose deaths, there's over 100 in whites. So most of what we're seeing is disproportionately from the white community. That doesn't mean that it doesn't affect everybody, but that's just the demographics that we see, and that's mirrored nationally. That's what we've been seeing national. So the CDC has also put out data for that as well. If you look at the maps that we've made of where these overdose deaths are happening and where the overdoses are happening, it's everywhere. The map is just littered from top to bottom throughout the entire county. So no area is spared, no geographical region is more affected than another. They're all there. Everybody is being affected by this. And what we've also seen is an uptick in some of the people seeking treatment, and I'll defer to you guys to speak on that over the last few years. So we've kind of developed a pathway, our group has, to figure out how people get to overdose, how they get to death, and how they start out with prescription opioids? Do they start out just using recreationally, like at a party or something? And how do they get to the overdose death? Is it I was using this drug and I didn't know what was in it, and then I ended up overdosing? And so mapping out that pathway has kind of led us to see visually where we can intervene. So there's 3 different ways that you can help prevent these overdose deaths. One is primary prevention, right? Don't start. And so a lot of that is education and messaging to some of the younger people. The secondary prevention is trying to get people the treatment that they need, right? So people who may be at risk for developing a substance use disorder or who may be at risk for addiction, helping them get into treatment when they do develop that. And then the tertiary prevention is stopping the deaths. And so that's distributing naloxone out into the community, making it cheap and available to the people who are overdosing and teaching them how to use it. So there's other harm reduction that we can do in terms of needle exchange, preventing HIV, hepatitis C, all of the things that come along with IV drug use. And so hopefully by hitting those 3 main areas of prevention, that we'll be able to start to chip away at this. It's going to take a long time. Like we're deep probably in the worst part of this. Some of the stuff that we're seeing nationally is like a small little ray of hope. So we've seen a drop off in the number of opioid prescriptions that are being prescribed by physicians. And 2015 was the first year that had started to not increase and started to decline, which is good. The CDC has come out with prescribing guidelines for physicians to decrease the amount of pills that are out there, and we've done a much better job of providing safe places for people to take old prescriptions to go and dispose of those medications. And then I think today is the 28th. It's National Prescription Take Back Day. So if you guys have any in your homes, please, you just did that, good. So you guys, please take those. You can, I know a lot of people don't feel comfortable, but any police station you can take your prescription to, and most pharmacies you'll be able to do that as well. So there's places for you to do it, just Google it, you'll find a place. But today's the National Day. So we've done that as well, and we've seen a lot more messaging going out to physicians on how dangerous these drugs really are, because back in the 90s the message was there's a low risk of addiction for people who are chronically on these medications, and now we know better. And so there's prescribing guidelines out there, and we're starting to see a little bit of a decrease. So a small ray of hope that maybe it might get better. But things like this are going to make the biggest difference. So increasing awareness and knowledge in the community, and then hopefully finding ways that we can all come together and put all of our super smart heads together and find solutions for everybody. Okay.
Thank you, Dr. Theobald. I also have the flyer today for where you can drop off those prescription drugs. And if you want to, you can take a picture with your phone and text it around or put it on your Facebook page so that people may know that they can drop off that information, those prescriptions. And then we can have work towards a safe environment for our community. At this time, we have Mr. Shea Halula, and he is a professional addiction specialist, director at Starting Point, Inc., and he has a bachelor's degree in psychology and communications from Concordia University, and then he's a professional trainer in substance abuse prevention and intervention programs, and he has been doing this for over 4 years in his current position. He also works with all sectors in the community around AODA issues. So let's welcome him at this time, and he shares with us. Thank you.
Good morning, everyone. The reason why I'm here and the reason why I do is I've had family members and friends that have been affected by drugs and alcohol. And really, this issue affects us all. And I'm really here on a couple of different hats. One, I work for Starting Point, which we are heavily involved in schools. I believe really if we're actually going to make a dent or do anything, we have to start early and often, especially with the kids and stuff like that too. So we do a lot of prevention programming. We also do a lot of early intervention too, because good kids make mistakes. I think back when I was a kid, I did a lot of stupid things. And some of the stuff I didn't get caught for, thank God, and other stuff. So the main thing is we have to realize good kids make mistakes. It's part of development. The brain impact and everything else, kids are learning. They cannot think past tomorrow or the next day. They don't think of consequences. So a lot of times we have to have programs and measures in place to help them when they do mess up, not to come down on them hard, to kick them out of schools or do this or that, but what can we do to help them get back to where they need to be? So I'm a huge proponent of that because, again, we just can't throw away kids to say, well, you have a problem. No, we're here to help. I'm also here as part of MCSAP, which is part of Community Advocates. It's a coalition. And what I like being a part of that community or that coalition is it brings a lot of people together. I know a decent amount about prevention. My background is also in counseling. I also work with sober living and different things like that as well. But you're bringing together from schools, all different types of sectors. Because again, I cannot do this alone. We cannot do this alone. We all need to be on this together. And honestly, it's unfortunate because this problem was probably, you could see this coming at least 10 or 15 years ago. And that is a huge issue for the simple fact is that, again, doctors' jobs are to fix. Law enforcement job are to protect and serve. And that's what they do, that's what they know. And again, as you can see what's happening, and that's what's got us into this trouble a lot of times. Again, you see a lot of the education, our doctor talked about it before. There's not much education that doctors get when they have to go to school about addiction. All they know is about treating pain and trying to help the people. And what we're trying to do at MCSAP and a lot of different places is come at this from all areas. We have to come at this from all areas because we can't do this alone. I work a lot of times with families who either have lost a loved ones or their kids are struggling. And that is really tough conversation and support to do it as well. And biggest thing is what I try to tell them is that there is hope. And you can try to say everything happens for a reason. Well, when you lose a kid to an overdose, and medical examiner said it very well, you know, their bodies look perfect. This should not happen to them. I have 2 small kids, and that's one of my motivators too, is, okay, what can we do to make their world safer and better? Because again, this is affecting all communities. I can go on for probably about 15, 20 minutes. I won't. I'm here to answer questions and stuff like that too. Like I said, I'm also a part of Sober Living. We have a male sober house. And I think one of the biggest issues is when people need help, where can they go? And that's a part of the biggest problem, really, is there's not enough treatment providers. If someone needs inpatient, where can they go? If they don't have the money, if they don't have the proper insurance, they're not going to get in. So what do? They try to do it themselves, or they end up ODing. It just is not a good system. The system really needs to be looked at. And when someone gets inpatient, where do they go after that? You don't want them going back with the home, because a lot of times it could be a toxic environment. So there's a lot of stuff that needs to be looked at. And really, everything has to be examined and looked. Because again, most of the things that we've been doing the last 5 or 10 years have not been working. And so it's nice to see different parts of the government, not all as much as it should be, re-examining itself like that too. So thank you for everyone coming out today, because this is a much better turnout than I anticipated. This is a huge, heavy topic. And again, I'm here to help and to answer any questions I could do. That's my job. So thank you.
Thank you. We're going to have Miss Rachael Cooper come at this time. She's in professional behavior health at ARCW. She has received extensive education in this area, and also she is a person that puts that education into action, and she's passionate about what she does, and she's going to come at this time and give an introduction to us, as well as explain to us her feeling on the opioid crisis and how we need to wake up Milwaukee. Let's welcome her.
Good morning, everybody. So, yeah, I'm Rachael. I've been working in this field probably, well, close to more than 4 years now. What I primarily do is slightly different. Most of my path at ARCW was via the needle exchange program, so providing direct service to people who are already in the throes of actively using. Within that, what ends up happening almost inevitably is there's a lot of work about frontline opiate overdose prevention work. So for those of you who don't know, there's a drug, naloxone. It reverses the effects of an opiate overdose. It's essentially a pause button. And one of the initiatives that's been around for a while, and thankfully it's increasing, is making sure that we get that to the people who are witnessing the overdoses, so people who are actively using. Most of the time, if an overdose is witnessed, it's going to be by somebody who isn't law enforcement, who isn't a medical professional. It's going to be by a friend, a family member, or somebody else who is using drugs of some sort at the same time. So where we come at it is, this is where that primary level intervention needs to be, because that's how we're going to save lives. There's a lot of factors to this, and I listened to everybody talk today about where they come from, and I know that my perspective is a little different, because when you work with people that are actively using, those are the voices that I hear. This isn't prevention, right? Prevention didn't work, and that's always going to be that way, right? Why people start using, there are hundreds and hundreds of reasons. Everybody's path is different. Some people get an opiate prescription for chronic pain and they become dependent on it. Some people are young, and like Shea was saying, all the stuff that we choose to do when we were young. I was lucky that when I was young, it was just pot, right? I smoked pot. I didn't, get into opiates, but now it's opiates, right? This is what people, I wish it still was that, right? It'd be a lot easier, a lot less dangerous in a lot of ways. But what we're seeing is those primary drugs of initiation, that's what we call them, like the things that people use first, it's opiates, right? So the curve is different. Access is different. So when you see somebody who's a 20-year-old female from somewhere in Milwaukee County who's using IV drugs, the question of how she got there is important to retroactively inform how we help. But in that moment, the space is, how do we get you the help that you need? And for those of us, who are maybe familiar with treatment or recovery, addiction, anything like that, we know that people don't like to accept help until they're ready to accept help. And it's hard for us. There's a lot of vicarious trauma that's associated with people struggling with addiction, because you want things to be better for them. It negatively impacts you, right? You are the loved one you are trying to help, and you have somebody that maybe isn't ready yet. So there's a lot of vicarious trauma to communities, to families, to schools. I'm sure everybody in this room has had a brush with the opioid crisis. Maybe you don't know that you did. A lot of times people hide their use, right? Or it's just pills, it doesn't matter. There's a lot of different things that can happen here. So one of the things that I've worked really hard on is essentially creating or working towards what we call a coordinated community response. Because when I see a person standing in front of me, let's just say it's Shea, there's a person here who's struggling with an addiction, but there's a lot of other things that might happen here. There's a lot of trauma. There could be a criminal justice history. There could be sexual assault. There could be domestic violence. There could be a lot of things that may have happened as a child. We don't know. So when you respond to stuff like this, you have to be in that mindset that it's not just the drug, it's the entire person's life. There's a lot of reset that has to happen. So with treatment, like Shea said, we need more treatment providers. There's a whole spectrum of treatment providers, and it's so hard to talk about because there's so many different ways that people can get help. Sober living, inpatient. People sometimes do get really wonderful help with the methadone or Suboxone clinics. There's a lot of different things that people can do, but if I'm asking you, how do I get help? Well, there's like 18 different answers, right? And it's hard to navigate the system. Even if you have the best insurance in the world and they're going to pay for it, it's hard to make that choice. So access is key, and immediacy is key, because from my perspective, when somebody is standing in front of me and they're going through withdrawals, I'm like, I want help now. My best friend died last week. I don't want to be doing this anymore. I don't want to have to tell them, well, we have to wait to see if your insurance covers it, and there's a waiting list, so it might be 3 weeks, right? And when we talk about what you were talking about earlier with these crazy opiates that are coming through, these synthetic opiates, the death rates are skyrocketing. They're climbing. They're still not going down. So we don't have time. We don't have time. It's an immediate response, you know. It affects all of us in different ways, but when somebody says, I'm ready for help, that's when we have to jump into action as a community, as a support group, as a friend of a family, as that person down the street that can call 911 or get somebody to care. If somebody reaches out, that's where we can all help the most, just individually. So, thank you. I really appreciate you guys listening this morning, and keep doing what you're doing, because part of this is just education and knowledge and how do we move forward together. And I see people nodding in the audience. Look at who else is nodding and go talk to them and say, like, how can we help? You know, a lot of really good stuff going on. So thank you guys.
Thank you, Ms. Cooper. At this time, we're going to call Dr. Annette Stokes. She's into family medicine, and she's the president of the Cream City Medical Organization, which we heard earlier is having their 90th celebration this evening. So we want to welcome her at this time, and she's going to give her introduction as well as speak on the opioid crisis, Wake Up Milwaukee. Following her, we will present the questions that we have, and we've had them online, to our panelists. Thank you.
Thank you, Mildred. I'm excited to be here this morning. I'm sorry I was running a little late because we are having this 90th event, and since I'm the president, there's lots of stuff to be done. But again, as Mildred mentioned, my name is Dr. Annette Stokes. I'm a practicing family medicine physician. I've been practicing 21 years, and I'm here just to talk to you briefly. I'm not going to take a lot of time, just to talk about prescribing of the different opioids that are out in the community. And what I would like to say is, first, when the medical education board licensing board decided to make mandatory a certain amount of continuing education credits, any physician, any practicing healthcare provider that has a DEA license, they have to do 2 mandatory continuing education credits each year for the next, I think, 6 years or so. And so I said, well, we have to do 30 credits already. And I'm like, well, why do I have to do extra credits, for this? And then I just thought about it, and I said, well, if I'm not part of the solution, then I'm going to be part of the problem. And so what we have found is that the prescribing practices of particularly family medicine doctors and those that work in primary care is part of the problem at this point. And so the prescribing practices that have come down, and it was initially presented back in July of 2016, and then it was mandated by the state in August of 2016 that we have to abide by certain practices in prescribing opioid medications. And so, with all that, I'm just going to say that, and again, I know the panel and some of the presenters prior to me have told you the difference between the different opioids and the synthetic and the non-synthetic. So, but where we come in as primary care physicians, as we treat the community, is that we have to put a lid on the way we prescribe. And the way we prescribe in our offices, the way we prescribe in the emergency rooms, the way we prescribe for acute medications or acute pain, and the way we prescribe for chronic pain. And chronic pain is considered pain that's lasting more than 3 months, or pain that's lasting more than what you expect once tissue has healed. And so what it is that we need to make sure that we're using other methods other than first-line opioids. You know, we need to use certain things, non-pharmacologic, yoga, meditation, things of that nature to help people get through some of these, massage, some of these painful conditions that they have. And if you can't get the pain under control, then you need to consider other, non-opioid pharmacologic agents like ibuprofen, NSAIDs, Tylenol, medications of that nature. And then as a last resort, and not the first resort, some of the opioids. And if you decide that you're going to use opioids, there's a whole list of, checks that you need to have in place. You need to make sure that you're not putting the patient that is in need of this medication at risk because they have addictive behaviors. They may be depressed. They may be, just seeking drugs for other reasons. And so, there's urine drug testing. You can also check. There's a registry that we can check as healthcare providers and as physicians to check to see if they're getting medications from other prescribers as well. So, and with that being said, we need to also go slow. Just don't have a patient come into the clinic or, the ER or whatever, and they have a painful condition, and then you give them 40, 50, Percocet or 40 or 50 Vicodin. That's not what, we should be doing, but I know we've had some practices like that. And, we have pain clinics where people go to the pain clinics because they have chronic pain, but they need to be monitored, they need to be managed in a certain way. So with that being said, I'm just going to say that from a prescribing standpoint, we need to pull it together as primary care physicians. We need to abide by what our law in our state tells us to do. And one of the big things is for right now, if a person comes in and it's acute pain and you do the appropriate assessment and you find that they need to have medication in the opioid family, not to prescribe more than 3 to 5 days worth. And if they need more, you may be better at giving them 2 prescriptions or making them come back so that, you can reassess them. So we need to, first of all, try non-pharmacologic interventions. We need to, number 2, we need to try non-pharmacologic opioid type of interventions. Like I said, NSAIDs, Tylenol, patches, analgesic patches, and we need to go slow. We need to abide by what our law is telling us to do as medical care providers and check these registries, do an appropriate assessment, and make sure that if an individual is on chronic medications for pain, that you're assessing that urine to make sure they're actually taking the medication versus doing other things with it. And so with that, I'm going to sit down because we're probably going to get more information from finding out what it is that you want to hear in our panel discussion.
Thank you, Dr. Stokes. At this time, we're going to present some questions to our panelists. The first question is, why is opioid addiction emerging at such a rapid pace? So we're going to start here, and I'm just going to pass the mic down. You can come up, actually, and stand up if you like and answer the question. Okay, so we're going to find out why is opioid addiction emerging at such a rapid pace?
Well, this is the United States. We like the quick fixes. And again, just kind of echoing what some of the people said, there's nothing wrong with pain. And I think a lot of times people don't want to experience any pain, so they put a lot of pressure on their doctors and people around them and stuff like that too. So again, it comes back to the number one thing is money. Pharmaceutical companies make lots of money off of pills, and it gets pushed. And because of that, is one of the main reasons why we're in this epidemic. Is it all their fault? Of course not. It's supply and demand, but a lot of it has to do with money and getting stuff pushed through. And because of all the money that's being made, there's so many pills out there that can solve everything. I mean, I still remember, Brett Favre had his Vicodin issues and stuff like that too. You can't blame some people for using it. I mean, look at all the commercials on TV. The one thing that always jumps out of my head is the Viagra commercial, the guy throwing the football through the tire thing. I'm thinking, if I can do that, I'd probably take Viagra too, right? I mean, you look at that. I mean, seriously. I mean, there's so many different promises that doesn't make sense. And again, every person is so different. And the problem is pharmaceutical companies, a lot of times, they make so much money off of us and off a lot of deaths. So that's where it really has to start. Thank you.
Stop. No. The other thing that while Shea was talking, what I was thinking about is we were just talking about how prescribing has changed, right? We're limiting the amount of painkillers that a person can receive. There is a culture in which a couple things, sharing medication is very normal, right? You see commercials about it, you hear these PSAs, whatever the case may be. But my grandmother sent my dog her opiates because she didn't like the way that they made her feel, and my dog had arthritis. She sent him United States Postal Service, and I'm like, please don't do that. Like, please don't. You're sending, okay, But this is the culture, right? So there's also an issue, though, because when we do start cutting people off of their supply of prescription painkillers, be them needed, not needed, it doesn't really matter. But if you do need opiate-based painkillers, or you do need pain management, or you do think that you need opiates, it's a hell of a lot easier than to buy heroin on the street than it is to buy prescription pills. And if you make that switch, and I have seen it time and time and time again from all ages, all zip codes, all racial demographics, if you make that switch, then that's when the deaths start to rise too. The heroin deaths, when people essentially don't know what they're doing. There's a lot right there where you make that switch. It's a very dangerous time, and so we hear a lot about it. We hear about fentanyl, carfentanil, heroin overdose deaths because it's dramatic, because that's how we cover things in this country, in the media. We hear the big things, the big dramatic things, but that switching point, we have to make sure that you were saying earlier, that these other pain management methods are available to people no matter what their age is, no matter what their issue is, because otherwise we're going to keep seeing it grow.
I don't know that I have much else to add, but I don't have much else to add. I think you're right. It's money, it's culture, it's multifactorial. There's not going to be one simple answer to why we are where we're at today. It's doctors, it's communities, it's families, it's all of it, and it all comes together and ends up in someone who has substance use disorder. And so I don't know that you can tease it out to one thing or another.
Sure. I just wanted to share this statistic. It said the U.S. makes up 4.6% of the world's population and consumes 80% of its opioids and 99% of the world's hydrocodone. The other thing, I was talking about families, and that's really my focus, and I talk about that a lot in my book, and generational, multi-generational drug abuse. And I'm also learning more about the brain changes that occur when somebody is addicted to opioids. And I found one study, it's in mice, but they look at the mother passing on brain changes even before she gives birth. These brain changes are present in her offspring and in the second generation. So if we are dealing with brain changes on that level, it's not then their genetic susceptibility that some people have to developing an opioid addiction is passed through the generations. So that's why I say it's so important if we can support and we can strengthen families, because the parents are the ones that can help these children. We talk about many people that won't seek help, that don't want to seek help, but yet their parents know what these kids are going through. And if the parents could be supported enough to really direct their kids and help them to choose different pathways, then I think that would be so important. So I'm a big advocate of community and really strengthening our communities and our families.
Yes, I concur with what the panel is saying, and it is culture, is big pharma, and being on the front line as a primary care provider, I think that we have had a paradigm shift, and now providers are more interested in what online is saying as far as their practices, as far as what they are as a provider, and so they want to get the best marks. And so they usually will have people come in requesting all sorts of medications, and if you don't give them those medications, they'll go right online and give you a bad report. And for some physicians that work in some of the bigger medical hospitals, that can be directly related to their salaries. And so they may be more compelled to give medications that they shouldn't be given in the quantities that they shouldn't be given. And so I think that's definitely contributing to this epidemic, because now it's almost like medicine is a business, and you have to get good ratings, otherwise you're not going to get big money. So that's what I think is one of the major problems and what we're dealing with as far as the epidemic, as well as culture and the brain changes and the other aspects of this epidemic.
Our next question is, why do people become addicted to these types of drugs? And could you mention some of the names of some of the drugs and why people become addicted to those types of drugs?
So if you look at addiction rates across the board for all drugs that are out there, probably the number one most addictive drug is nicotine, right? So if you look at, for people who use just one time, what percentage of them go on to become like chronic users, it's 32% for nicotine. The next number two is opiates. It's like 28%. The lowest on the list is marijuana, which is about 9%. Alcohol is in the teens, cocaine is in the teens. And so it's the reason why I think that opiates are so addictive is that whatever gets into your brain the quickest is much more likely to have changes and affect your reward system in your brain, your reward. And so the nicotine, within seconds of smoking it ends up in your brain. And that's true with IV drugs, IV opiates, and then also with the opiate pills. So they're very highly distributed to their brain, and then they cause changes there and affect your reward system. And so then that in turn alters behavior. So there's a whole other host of reasons, and for people who are at risk for having substance use disorder, but just looking at the drug itself across the board, it's probably the most addictive aside from nicotine.
I also wanted to add, some of the drugs that we're seeing, I can list them. I said it's like being in your high school or college chemistry. A lot of them are fentanyl analogs, and we know that fentanyl is about 100 to 200 times more potent or more powerful than morphine. And heroin is up to 5 times more potent. So these are very powerful drugs. And some of the, if you want to know the names, some of them we're finding is furanol fentanyl, desproprionyl fentanyl. There was one overdose death from a U47700. I had one, and then I think they made that a Schedule I drug, and maybe that's why it's gone. We don't see that one as much anymore, but that was also an opioid, a synthetic opioid or designer opioids. This is what we're calling these man-made opioids. Acetylfentanyl, acrylfentanyl, and 2 days ago I just had a death from the first one I'd seen of this one, cyclopropylfentanyl. And I called the toxicologist. I'm with Waukesha County, and we send our toxicology to NMS lab. It's a huge national lab in the Philadelphia, Pennsylvania area. And he said that death was related to cyclopropylfentanyl. And it wasn't even quantitated. Normally they give us like how much is in the blood. They don't even quantitate that. It's so new. So we keep getting more and more of these newer analogs. And the changes in the brain, some of these drugs are additive with other drugs. So you need less of that drug, can develop an addiction that much quicker, and also cause death that much quicker. So if you have 3 or 4 of these drugs in your system, you're just asking for it. You know, and then we've seen we've seen cases with heroin, and there'll be some heroin, but then there's also fentanyl, and then there's these fentanyl analogs. So that's 3 different drugs basically acting on your brain. So I think that's why we're seeing more overdose deaths. And in some of these deaths, I think, are people that may be just experimenting. I mean, you might have people that maybe tried it for the first time, or they're fairly new with the scene, or they may even not know that it is, what the drug is. They might think that it's something less toxic. So I think that's why we're seeing more deaths and likely going to see more.
I agree with the panelists. And from the primary care standpoint, some of the drugs and their common names is OxyContin is oxycodone. Hydrocodone is Vicodin. Then you have the morphine, the codeines, and then you have some of you may be familiar with tramadol, which is also a pain medication. And I believe that the reason we're having people become addicted to it is, of course, the changes in the brain. You have certain receptors that are called mu receptors, and they get you really euphoric. And so people like to feel that way. If they have underlying medical conditions or psychiatric conditions, depression, anxiety, or they're just going through a difficult time, who knows what, life happens. They may be looking for something to make them feel better. They want to feel euphoric if they're down. And so these drugs can do that. But then when you add, the opioids with, if you start mixing drugs with the benzodiazepines, then they get, really excited. But the problem with that is that when you mix those two, you increase your possibility of, not breathing, 3 to 5 times more. So you actually, stop breathing. These medications have a very strong effect. And so, when you have a population that's under duress and they're looking for something to make the pain go away, whether it's really truly physical pain, pain in your body, your muscles, or if it's psychiatric pain, they're looking for an alleviation. And I think that's why we're seeing this big epidemic right now, this crises that we're dealing with here in the United States and in the cities and counties and all over America.
Millie had mentioned that I should mention. No, there's a lot of these names that are getting thrown around, but fentanyl is something that is legally prescribed, right? It's a patch, it's a pain patch. It was developed in a lot of ways for people who were terminally ill, for whom addiction wasn't going to be an issue. It is also implicit in what ended up killing Prince and U-47-700, Michael Jackson. There's these names that we keep hearing over and over again, these drug poisonings that happen. People think they can be as careful as they want to be, right? They think they know what they're doing. They're trying to be safe. Why this has gotten to this point also, to me, has to do with fear. Drugs in general are used, and a lot of times, to escape some sort of pain, right? Mental pain, physical pain, like we were just talking about. If that's your coping mechanism, if that's what you learned, if that's how you cope, you have to redevelop those mechanisms. And that's a really hard thing to do for people that are in the best mental and physical health. Redevelop. I mean, how many times have all of us said we're going to diet, or we're going to run a 5K, or we're going to do whatever it is, or cut carbs out, or, right? I'm going to do this. And it's hard. So when people are scared, it's a really hard place to find motivation to change. So the cycle just kind of continues. So that's what I was thinking about.
Well, and I think one population, too, that gives out meds is dentists and stuff like that, too, where a lot of times, a lot of Vicodin and stuff like that, too, so we can't forget them kind of adding to it. There's a lot of reasons why people use, and some people, opiates don't do it for them. And again, there's a huge genetic makeup. Is there a family history? And for some people, I mean, their life truly sucks. You can't blame them for perhaps using, for escaping and stuff like that, too. The biggest issue, as most of the panel said, is if we were going to take it away, then what are we going to replace it with? And that's the big thing right there too, is it's going to be the Suboxone, the methadone, the Vivitrol, what's going to help them, because they need to get to that next gap. And it's going to be not 30 days, it's going to take 60 days, 90 days, 6 months. It really takes 6 months. Think about like what Rachael was saying with habits. It takes a while to reprogram the brain. And again, some of these people, the only thing they have in their toolbox is when life goes wrong, something happens, they smoke or they inject. That's all they know. And that's what they learn at an early age, maybe with their friends or parents. So it's up to us really to help them and give them the programs that they need.
So for those of us who are not in the medical profession or don't have the experience that you have, we had a young lady that was to be here today. She couldn't make it, but she was not, she didn't become addicted to the opioids because of, just using as drugs, but she was prescribed by a doctor. So what is the safe period of time that a person can take this medication and not become addicted and not be in a situation where their life has been traumatized?
The first thing that came to mind when you asked that question, a couple of things. So from what I understand, there's a difference between dependence and addiction, okay? So dependence, your body becomes dependent on drugs. That's why we build tolerance to certain things. This is why the first time that you had a glass of wine, you were pretty tipsy, and then later on you can have a couple and still feel fine, right? This is the same thing with opiates, right? Your body will become dependent on them for the effects that they produce because, like many of the panelists have talked about, your brain changes to accommodate things that are in your system. So if you are habitually using, and I'm not going to use the word addicted here, I'm saying if you're using habitually because you have been prescribed, the number that I've heard is 21 days you're going to be dependent. Now, you can adjust that because that was the last thing that I heard, but just please adjust that. But there is something here in which there's a difference between a dependence and an addiction, and the addiction part of it has to do with you can't stop. You are going to engage in behaviors that are detrimental to yourself, to society, to the people around you. The addiction part of it is a little bit different from the dependence. So that was the first thing that I heard, and I'm going to let you fix the numbers because I know that I was wrong on that. But there's a point there at which it turns, right? Like, I need this to function, I need this to be okay, or I need this to not be in pain, and if I stop using, then I'm going to be in pain. It's kind of how you phrase the question. So some people can use for a really, really, really long time and be completely fine, and they never engage in negative behaviors. They take their pills as they're supposed to, and they're fine. They live a normal life. Like Shea was saying, there's these other medications that you can be on, methadone or Suboxone, which are used to wean people off opiates. And they're opiates themselves, right? It's kind of like a nicotine patch. It's the same kind of idea. But there are people I know that have been in clinics for 10, 12 years because they don't feel like they're ready to stop, but they're safe. They're being safe. So we kind of can't guide how people go through this, but if somebody's saying, I'm not ready, trust that word. They're not ready,
I won't even attempt on the days and stuff like that too. I'll just talk about there's so many factors, kind of looking at the counseling or treatment part. We do a really bad job counseling and treatment. There's so much relapse. And the relapse rate, you figure if someone goes inpatient or treatment, they're going to relapse. It's almost, I don't want to say a guarantee, but it is a guarantee. And why? Because there's so many factors. Are they using other drugs besides the one that you are listening to them? Do they have mental health issues? There's so many different factors. And because of that, to me, it's really hard to say. I'm sure they'll give a number where it's 20 or 21 days. But again, for each person, it's so different. And that's the one thing, too, is when you are getting medication, you don't have to take it. A lot of times we think doctors are sacred, and we put them up here. A lot of times do. And again, it's very important to ask questions, especially if you have elderly parents, whoever it is to ask questions, and you don't have to take it, and you certainly can get rid of it. And I think that's, again, making sure you make the right thing.
I don't know about specific days and how long you have to be on it to take it, but I do want to just do some definitions really quick because we've been throwing around a lot of terms. So Rachael did really good about dependence. It's your body only acts normally in the presence of the drug, right? So then you have a tendency to go through withdrawal. Doesn't mean you're addicted. Potency is another issue. So we talked a lot about potency. That just means the amount of drug that you need to get an effect. So just because fentanyl's more potent, right, you just need a smaller amount of drug to get the effect. So in terms of how long you have to be on it, you can be on it for 3 days, right? What we know a lot, or what we've learned a lot in the last, say, 10 years, is that genetics play a big role in how you metabolize the drug and how your body reacts to the drug and how it acts in your system. And we don't know that. We don't know what your genetic makeup is, or yours, or yours, or yours. And when they do these, when the drug companies do these studies in patients, we try to get a wide variety of patients so that we can make generalizations, but that doesn't mean that applies to you or the person sitting next to you. So if it's 21 days, if it's 3 days, if it's 10 days, everybody is at risk because these drugs are addictive, period. I mean, and you need to weigh the risks of the benefits. So how many of you guys have actually taken a Vicodin or a hydrocodone? Yeah, I have. I got my wisdom teeth out. I took one. And I was in college. I went to class. I didn't remember the class the next time I went. I mean, I've broken bones. I've had them for broken bones too. Those things are real painful, right? And I mean, there is a place that you should take those medications. So I don't want to scare everybody. There are plenty of people who use these medications for painful conditions, right? And some of you guys have, and I'm hoping none of you have a substance use disorder. But so there are people who take them and don't have a problem, okay? But there are some people who do, and it's hard to identify. There are some risk factors. So males are more likely to develop a substance use disorder than females. Ages like from 20 to 35, that risk is a higher risk than, say, older or younger people. What did you say? I'm 1 of 2. Yeah. Right? This guy. And people who have an underlying psychiatric disorder are much more likely to develop. So you need to know those high-risk conditions to say, like, when I prescribe this medication, like, a lot of counseling needs to go with it, right? And so people need to be educated so that they know what they're using and when they use it.
Yeah, and I was just going back to the family and knowing your family history. If you know that you come from a family of addictions, be it nicotine or even alcohol, drugs or alcohol, you may be at more increased risk. You know, in my book I talk about mental health disorders, anxiety, depression. There's a lot of that. I'm amazed how many times the people that overdose on drugs are also on benzodiazepine, their Valiums, their Xanax. Oh, I'm sorry. So also knowing that, because stress actually decreases your ability to prevent addiction. If you take these drugs, the stress might actually make it more likely for you to become dependent and to become addicted to these drugs. So it's important to know yourself and to also know your family history and to gauge those risks. Like we say, obviously these drugs are here for a purpose and they're necessary when we have surgical procedures or for cancer pain. You know, we're never going to get rid of them, but we just have to monitor and know ourselves to anticipate how that drug might affect us if and when we do have to take it.
I don't have any more to add to what the panel has said, but I would like to say that for some reason in our community we feel like no one's addicted to opioids. And I just want to stress the point that opioid addiction is significant in our community as well. As long as we have healthcare providers prescribing, medications that people could become addicted to, it is in our community. The Vicodins are in our community. Oxycodone is in our community. Ultram is in our community. So these are medicines that are being prescribed for acute pain and chronic pain, which that is not an indication, at this time. So don't think that this is not affecting our communities here, but they are. And so I just wanted to say that.
Thank you. I've been receiving notes. We have a lot of questions. So at this time, we're going to allow you to line up and to ask the questions that you may have. And those of you who handed me questions, I'm going to give them back to you and you can ask your question. We have a phenomenal panel this morning, don't we? Yes. Thank you. So at this time, we're going to ask questions. If you have comments, we'll save those till later, but we want to have your questions at this time. Thank you.
I'd like to ask the lady here a question, but I want to share a thought process. Please be careful when saying everybody here. Say some, because not everybody knows everything about that. My question is, could you expound on the drug that negates the effect of opioids and the availability of that drug to the community?
So thank you for your comment. So the drug that I mentioned, naloxone or Narcan, is a drug that's used internationally. What it does is it reverses the process of the opioid overdose. So one of the things that you mentioned earlier was about the lack of breathing. So what happens is overdoses, opioids in general, they cause your breathing to slow and eventually stop. And once your breathing stops, then your heart is going to stop. That's kind of the process of what happens. This drug prevents that, it stops that in the middle of it happening. It's a really cool thing. It's been around since the early 1960s. It's very, very effective. It's saved hundreds of thousands of lives. We don't really know how many lives it's saved. How you access it, there's a couple different ways. If you're here in Milwaukee County, a couple things. So it is available at pharmacies. Not all pharmacies. I know that Walgreens pharmacies are now all supposed to stock it. Same goes for the Roundy's pharmacies and CVS. That doesn't necessarily mean it's in stock. So if you're concerned about this, you can call ahead to your local pharmacy and see if they have it in stock. Now, there's a couple different ways that this drug can be used. It can be used as an intramuscular injection in the event of an overdose, or it can be a nasal spray. For a lot of people, it's much easier to use the nasal spray version of it because there's no needles. You don't have to be worried about anything like that. The cost is a consideration. Some insurance plans will cover it, and you can get it for a copay. I'm not going to speak to that because I don't work in healthcare per se, and the insurance question is something that I'm just not going to make any guarantees about. If you get a prescription for it from your doctor, obviously it's going to be covered under your insurance, but it is available over the counter without a prescription. Now, if you are interested in carrying this with you, it is a completely legal thing to carry with you. There's no concern about that. What I would advise, if you want it for free and if you want to go through the whole training on how to use it, how to recognize an opioid overdose, you can call the AIDS Resource Center of Wisconsin. I can see people reaching for pens. So the number is 414-225-1608. And that's going to take you to the prevention department. That's who does all of the trainings. And when you call to say that you're interested in being trained with the naloxone, and for those of us who, it's NALOXONE, naloxone. It's a really cool thing. It's been super, super effective. And ARCW will get you trained up, whole thing. You're going to know exactly how to recognize and reverse an overdose. The other cool thing, this is just the last plug, and then I'm going to pass this back over, is that it can't hurt you. This drug can't hurt you. All it does is block your opiate receptors. It doesn't have any medical interactions. It's not going to hurt you. And that's why it's so easily accessible, because even if somebody's not using opiates and it's something else, it's not going to help, but it's not going to hurt. So that's a big key thing here.
Thank you.
Good morning. I have just a comment, and it's not long because it leads into my question. But I know that the Wisconsin Medical Society is a pretty powerful lobby group or membership group. And this is a three-part question. One is, when you get prescriptions, a lot of times you get 50 tablets for something that you may only need for a couple of days. Is there a difference in what you end up paying for 50 tablets as opposed to 10? So is it a money-making issue? Two, I know that there are people that if their kids are having dental or medical, or their parents, somebody that they're responsible for, may encourage the doctor to give medication, not necessarily for them, but for that provider. And third, when we talk about the medical society being a powerful entity, just like child welfare, you have mandatory reporters. Is it possible to have mandatory reporters when you know someone is abusing drugs?
So in terms of the prescriptions, there's actually been some studies that have come out that are really fascinating, looking at how much of the prescription patients actually use after surgeries. So like if you get your gallbladder taken out, if you have some of the most common surgeries, so partial mastectomy, total mastectomy, laparoscopic, removal of your gallbladder, all of that stuff. And what they saw is that people use probably about 30% of what they're prescribed. Maybe only a couple days worth of the tabs. And so they have a bunch of medication left over. And then that goes into their medicine cabinet at home. And then like some teenagers bored on a weekend and they go fishing for pills. So that is a definite issue. And some of the things that Wisconsin has done to address that is, and nationally they've done it, the CDC put out prescribing guidelines for physicians. Wisconsin now requires all physicians to check the PDMP, which is the Prescription Drug Monitoring Program. Anybody who gets a scheduled prescription, so a scheduled drug, like an opiate, a benzodiazepine, anything like that, it automatically gets uploaded into a Wisconsin database. So you can see who prescribed it, how much got dispensed, and on what day they got dispensed that medication. And so if anybody's getting a prescription for longer than 3 days, the physician is now required to look into it. To speak to why we're giving so many pills in one prescription, I don't think it's a money issue because I don't make any money off of that. I think it's an ease issue, right? So like people don't, I mean, right. So I mean, right. So part of it is like, well, I don't know how many they're going to need. I'll just give them what I think like might be the most they might need, and if they have leftover, fine. But then they don't have to come back for a prescription or call me back. And so it's easier for the doctors to do that, but it's also that's a loaded way to practice, right? Like I'd rather somebody come back for that if than me do it a little bit extra work. So I think that's part of the issue. And then in terms of the Wisconsin Medical Society, it is a very powerful group, especially in Wisconsin, and they have been involved. So the Milwaukee Cope Project has had a round table meeting, I think about quarterly, where we've gotten all different community players to come to the table. So the Wisconsin Medical Society, we've had the DEA there, we've had ARCW there. And so we are kind of coming together to try and figure out different ways to address this. And the Wisconsin Medical Society is involved in that group. And also on our Milwaukee Cope website, one thing that we've done, which I think is super important, is we've taken an inventory of everybody in the county who's involved in this issue, right? Because there's so many hands in the pot, so many people doing different things, and we didn't really know who that was. And we have a list of them and what way that they're involved. So even the Wisconsin public libraries, the Milwaukee County public libraries are on that list because they provide education. So if you guys are looking for somebody to come and speak at your wherever, like at your school, at your group, that you can go to that resource. It's available on our website. Just Google it. And you guys can download it and find like, hey, I want somebody to come and train people on naloxone, right? Or I want somebody to come and speak to our, my high school students or my Boy Scout group or whatever. They can look on that. That resource is there for them to know who's doing what in our community. And then in terms of treatment, we have a card that I forgot to bring today, so I apologize, that the paramedics are actually passing out. You have it in your car? Yeah. Yeah, that paramedics are actually passing out because a lot of family members, when they show up to the scene of an overdose, have questions and want to know what they can do to help. And so they hand this card out, and it has where you can get treatment. And really the bottom line is if you call 211, they'll direct you to the right place. So that's another issue, is how do you access treatment when it's there? I got off topic, sorry.
That's great, thank you.
I have a question, but I also have a little bit of a statement, which I think is really key. I get very upset when I hear providers, doctors say that the opioid crisis is within the white community. We have had an opiate crisis for generations, for 20 years or more. It came up And, you know, by any other name, it was heroin, it was oxys. But what's gotten people in crisis is the IV drug users, okay? And those tend to be white kids, okay? And that, you know, that also opens up the vector for HIV, a lot of other types of really serious diseases. But what I wanted to say, to ask is, with opiate users, the recovery is long term. And I'd like to know who is promoting harm reduction treatment techniques, which does not include the fact that people have to be abstinent only in order to be cured or in recovery. Harm reduction assumes that we are a drug-using society. We are. America is. And so we need to train more treatment providers that are culturally competent, and we're not. We used to have the Minority Training Project to train minority people for go into the community. That's gone. So I'd like to know who's advocating for harm reduction treatment techniques and philosophies and policies. Thank you.
Well, I think one of the main places she left, the AIDS Resource Center a lot of times does a lot of the harm reduction and policies and stuff like that too. And I think a lot of times, especially with the heroin issue, a lot of times does take not the 30 days or 60 days. It takes the 6 months to a year to really reprogram the brain. And that's why a lot of times going to inpatient for 30 or 60 days is putting a Band-Aid on the problem. And the problem with that too is the lack of transitional service after that. Are they going to a transitional house after that and also getting some intensive outpatient treatment? Because if you're an inpatient, then you should go to some type of sober living. You should do some type of intensive outpatient treatment. You should go to some support groups. There's got to be a lot of levels and stuff like that too. And the problem is those places are not always all there. And there's some places that have Suboxone programs to get people off. And, you know, those really should not be, people should not be on those for years and stuff like that too, Suboxone, methadone. I have a problem with that. Again, I know people have to get what they have to get, but a lot of times they then replace the addiction as well. So I know the AIDS Resource Center and some of like our McSAP stuff like that is trying to push that we have enough competent resources. It's an uphill battle, especially just because, again, there's a lot of layers to it.
I know that with the recent second iteration of the HOPE agenda, that they allocated more funds to developing treatment and getting people to those areas. And so there's been a lot of messaging from the community back to the politicians. And so another thing that came out with the HOPE agenda too was that initially if someone overdosed, there was a Good Samaritan law where the person who helped the person who overdosed was immune from getting prosecuted or hauled off to jail. So as of July of this year, now the person who overdosed has immunity too. Previously, they thought the only way to get that person treatment was to haul them off to jail and put them in jail. And after lots of messaging from the community that that's not the right answer, because after people overdose, they weren't calling the ambulance to take them to the hospital. And that's an issue too, is that they are listening. Sometimes it's a little bit slower than we would like, but things are happening to move towards that. And so I know that Milwaukee County has made an opioid task force that involves a lot of government officials and some other community members.
That meets today at 10.
Yeah.
It's meeting right now.
Yeah, so it's meeting right now, and so they are working towards trying to address this public health crisis.
Well, I guess I just had kind of a question. Because I see a fair number of people that have been through rehab maybe 3 or 4 times, you know, parents, I don't know if they're mortgaging their house to send these kids to rehab and they still overdose. And we've said that addiction with the brain changes is a lifelong struggle, a lifelong process. And I always remember Philip Hoffman, the actor. He'd gone years without using, and then he overdosed. Is there something more long-term, or maybe that's what I'm thinking, more of a community involvement where people that have gone long for many years can maybe give back to help people that have already been through rehab and now they're into trying to reintegrate into a regular life, or at least a more a life without using substances?
There's a lot of peer specialists in peer coaching that's going on a lot of times with that, especially at the state level. The one problem with that is there's not as much training as there needs to be. There should be a lot more people out there. The other part of that, when you have people who been there, have done that, it's also a slippery slope, because just because this worked for me does not mean it's going to work for you. And every situation, every experience is different. And so it's very good because, again, that's why sober living works very well, and that's why peer kind of specialists or coaches work. But again, there's so many different factors with each one of those. So that's out there. That's something that's being pushed statewide and nationwide, but it's something that's very good.
I would just like to address the harm reduction. As part of being the president of Cream City Medical Society, which is a society that is our clarion call, is about the disparities that we have in healthcare and all healthcare. And so I think when you have the HOPE initiative, maybe you should bring us to the table as well. And I think another big issue that we have is that when we look at the heroin addiction, and we look at the deaths that are occurring, and now all of the mandatory reporting and all of the mandatory this and the mandatory that, being in the Black community, it makes you think, well, where was all of this when there was the crack epidemic that's been out? We didn't have mandatory CME. We didn't have all of the reporting that we have to do. We didn't have hospitals, and I was just watching a report somewhere in New York. They have controlled bathrooms where if you want to come in and shoot up heroin, they have cameras, they have Narcan, they have all of that. And so I think that there is this kind of just anger in our community, because instead of making places and programs for people that were addicted to crack, we just sent them to jail. Now we're sending them to counseling. We're sending them to hospitals. We have, all the harm reduction in place. And I think that, as part of what we are going to do as a clarion call for our community on behalf of Cream City Medical Society, we need to be brought to the table so that we can address the issues that are in our community.
So we ask that no one else come, please, for questions. You all are good. So we want you to ask your question, and then we're going to have maybe one person to respond. The person who can, all of them are phenomenal, aren't they? I mean, it's just rich. So, okay.
My question is, and heard you guys speak about having the doctors to reduce the amount of prescriptions they give to people. Would they also be looking at alternative medicine? Like I had abdominal surgery in February, and a doctor in the hospital gave me opioids. And I was like, I don't want this. But once I left the hospital, I went back to my own treatment. I do ginger chews, which is good for pain. But so are they also looking at that? And if not, are you guys looking to try to push that as well?
What's the alternative? Who wants to answer?
I just think the mandate is that, yes, we need to find non-pharmacologic ways to treat, acute pain. Opioids should not be the first choice. And so if ginger or massage or, meditation, yoga, whatever helps, of course, and that should be one of the major things that we're looking at as well. And then if that doesn't work, then you're looking to prescribe something that's not an opioid. You're looking to prescribe, or even over the counter, the Tylenol, the ibuprofens, and even combinations of Tylenol and ibuprofen. For acute pain, opioid, oxycodone, Ultram, tramadol, that is not what we should be doing at this point. And that's what the mandate, the new prescribing indications are all about. And then if we do have to prescribe them, the opioids, go slow, use the least amount, 3 to 5 days. And then if you come to a primary care doctor's office, and instead of prescribing 50 pills, like I said before, you could give maybe a prescription for 10 pills, and then give them a second prescription if you're trying to limit that phone call back. Because, statistics show that filling that second prescription probably won't happen.
And if you look at the pain clinics, so a lot of anesthesiologists run pain clinics for people who have chronic pain. Like, opioids are like the third line. So they'll do injections for back pain. They'll do lidocaine patches, like a lot of different modalities to help people. Steroids, NSAIDs, all of that good stuff. One of the barriers, though, is that if you look at what insurance companies cover, if you go and try and fill your prescription for oxycodone at it's $4, right? You go and try and fill that prescription for lidocaine patches, oh no, it's not going to be covered. That's going to be $100. And so there's a lot of barriers just at the patient level for getting access to some of those treatments for the alternative ones. A lot easier for people to go pick up their opioid at the pharmacy. Thank you.
Good morning. My son David died from drug addiction last year. The drug that killed him was from England. It was hard for the doctors to realize what it was. My advocacy is for children. My son was ADHD, and in the school system in the 3rd grade, they couldn't handle his activity and suggested that we do something. So being an older, stupid mother, excuse me. Thank you. We put him on medication, and that's what led to his drug addiction. I just wish that teachers could be educated into children who are ADHD. When they disrupt the classroom, the parents shouldn't be told, put the kid on drugs. Whenever I talk to parents and it is suggested to them that their children be put on drugs, it is a life-altering experience because he was never able to think normally again. He had been altered. And so he started to self-medicate himself through his life. And so I'm trying, when I meet parents and people say my son should be on drugs, to say, don't do it. Think of some other way. But teachers have to be educated. And also, I've been through hell and back again, so I know a lot about drug addiction, okay? Because as a parent, you do learn a lot. There are so many clinics in this city that are drug pushers. And I don't understand. When I would complain about them, one in particular, they would say, oh yes, we know. We're working on it. We know this person is bad. Nothing's being done to this day. And also Suboxone became a constant drug. He was put on it so long, and I kept feeling something's wrong. This is supposed to be a short-term drug. So I could go on and on because I know a hell of a lot about drugs and rehabs and everything as the mother of a drug-addicted child. But my advocacy is for children, little children, that are altered at very young ages. All right, thank you.
So how can we get the word into the school systems and into the communities? Do you have a vehicle that you all are using to get that information out, or how could we make sure that that is available for instructional purposes? One person, please.
Or a DPI person left. So Department of Public Instructions, and we work a lot of times with schools, but a lot of times the in-services, the teachers need to know what's going on and stuff like that too. There's nothing wrong with a kid wiggling around and stuff like that too. Like she said, you know, the kid has attention deficit, then let him go to the back, let him do some stuff. There's a lot of different techniques and stuff like that teachers need to do. I think one of the biggest problems sometimes teachers like the quick fix, and they don't want to have to deal with the issue or just actually teach. Again, we work a lot of times very closely with a lot of schools. That's where we're also on a lot of committees and stuff like that too. And then also there's a lot of stuff going at the state level where they're trying to put in a lot of more mental health education and trainings for schools, for law enforcement, stuff like that too. That's the key.
Okay, thank you. Next question.
Beautiful job, panel. I have a quick question that's about cocaine specifically, but might relate to other drugs. My understanding is that when a person gets a dirty drop, like when they find, when you get a urine test and they find the drugs in your system, that it's the metabolites that they find. They don't find cocaine, they find what your body turns cocaine into. I was wondering, is there any research being done on possibly producing the metabolite as a tablet of sorts, where a person could take it and it tricks their body into thinking they've already had some cocaine and might help them in their recovery? Like maybe put the metabolite in their system to such a degree that it'll make their body think that they've had a bunch of drugs and they won't want to take any more drugs, but without endangering their health or getting them high.
Who wants to answer that question? Okay, Doctor.
So the urine drug screens, you're right. It screens for benzylecgonine, which is a metabolite of the cocaine. It's an inactive metabolite. So even if we gave that back to them, it's not going to trick their body into thinking that the drug is there. So part of the issue why opioid replacement therapy, so like methadone and Suboxone works for opiate abuse, is because it still hits that receptor and it prevents the patient from going through withdrawal, right? So there's not a big withdrawal phase from cocaine. So people who habitually use cocaine, they don't go through withdrawal necessarily like you do from the opiate, but there's really no good therapy for cocaine abuse like the opioid replacement therapy. There's nothing out there that could potentially work. So and part of that has to do with like your dopamine reward system and all the mechanisms in the brain.
Thanks for coming. Appreciate your professional time for all this. I just wanted to say I was watching Democracy Now! Last night, and the doctor they were interviewing was from an Ivy League college, and he was saying that the naloxone, is that the name of the drug? The naloxone, the drug companies that provide naloxone, since the police departments have started buying it so that they can help people that are in the process of almost dying from an overdose, they've jacked up that price tremendously, so they can make more money. Is there a way that we can, maybe we could somebody could talk about ways to combat that, could we boycott those drug companies, find out what they are, Google that, and then boycott them, or, definitely talk to our elected officials, that kind of thing. And then my other question was, what is tramadol? Yeah.
Who wants to answer?
Yeah, so that's a huge problem that these drug companies have increased the price of naloxone now that demand has gone up. And that's just part of the money and the business of it. And it's really sad. I'm an advocate for capping like what they can get, but I mean, they have such huge lobby against Congress that I don't know that that'll happen, right? It's the same thing with gun control, you know? And so it's, I mean, as silly as it is, that's where we're at. Tramadol, so what tramadol is, it's almost like oxycodone plus venlafaxine. So it's like an antidepressant plus an opioid in the same pill. And so it is an opioid. It has the same addiction potential like oxycodone, like Vicodin, like hydrocodone. It has the same abuse potential. It causes the same symptoms in overdose, pinpoint pupils, coma, trouble breathing. But it has all these extra effects where it works like almost like, you know, Prozac or other medications like that. So it has a whole extra subset of side effects than, say, oxycodone. The fascinating thing is due to drug company lobbying, when they first had that drug come out, they said that it has a real low abuse potential, even though we had a bunch of information from Europe that that wasn't the truth. And so they scheduled it where it was not a scheduled drug. So it wasn't like oxycodone. So PAs, NPs could prescribe it at lib, and it was messaged to doctors that it wasn't that. And I was even taught in medical school from another physician when I was on service that it was a NSAID. You know, it was an anti-inflammatory, which is also not the truth. So physicians were, from the drug companies, taught wrong about it. Now we're a little bit better, and the scheduling has been changed within the last year or two. But it's all has to do, we are one of 2 countries that allows direct consumer advertising from pharma, us in New Zealand, right? And look where it's gotten us. That should stop. They should stop. Yeah. Oh, sorry.
And I remember when I first started prescribing tramadol, we were told, well, it's new, and so you just tell the patient when they come in that the ones that you know are drug seeking that this is a new medicine and that it is better than the other stuff. And so we started prescribing it that way because, of course, we were told that it wasn't addictive and all of that. And so, yeah, or strong, right? And so we were prescribing it, and the patients didn't know what it was because it wasn't the oxycodone, it wasn't the Vicodin, you know, it wasn't, you know, the other medicines that they were Percocets that they were very familiar with. So it's just absolutely absurd.
It's true. At this time, we're going to take your questions, but we want each panelist to give your contact information. Each of the panelists, please give your contact information and say it twice and slow so we can get it. It's being televised, so we're going to make sure that people can contact you. There are a lot of questions. We can't get to all of them here, but there will be, I'm sure, a lot of people that have questions for you, and you all are professional and passionate, and we appreciate you being here to be accessible to our community. So just give your name, your contact information.
All right, so my name is Rachael, Rachael, Cooper, Cooper. The best way to reach me is via email, which is rachael.n.cooper@gmail.com.
I'm Shea Halula, and I'll make sure I spell that. It's Shea. Last name is Halula. I work for Starting Point, and it's always easier to get a hold of me by email. My email's long, I apologize. It's director@startingpointwi.org. So it's director@startingpointwi, that's all one word, .org. Or you could just look up Shea Halula. There's not many of those. And you'll find me too, so either way is good.
I'm Jillian Theobald, Jillian, and Theobald, it's Theo, like Theodore Roosevelt, and bald, like you don't have any hair. And my email address is jtheobald@mcw.edu.
Yes, I'm Zelda Okia. I'm an associate medical examiner for Waukesha County. I also have cards available next to my books there on the table. I will give you my personal email because that would be easier to access. It's Zelda Okia, my name, no space or anything, ZELDAOKIA @gmail.com.
Hi, my name is Dr. Annette Stokes. That's ANNETTE, Stokes, STOKES. And I'm from Innovative Healthcare, also the current president of Cream City Medical Society. I'm going to give you my Cream City Medical Society so I can keep this above board here. And the email is ccms.mke@gmail.com.
Thank you. Our next question, please.
I was really elated to hear so many comments about what's being done for profit and not really being done for the patients and the clients themselves. And there's a new group that was put together by the governor's office, and the name of it is Wisconsin Voices for Recovery. What Wisconsin Voices for Recovery is doing is privatizing only addiction recovery. And I know firsthand because I was supposed to be part of it, and when I insisted that we also talk about simultaneous treatment for people with mental health problems, I got thrown off. So the point is we need more advocacy, and we need the professionals to please come to the advocacy organizations and ask for help. And what my significant other, Jody, didn't say about her son, David, was we ran into a problem because of HIPAA. David was treated at Rogers Memorial in Brown Deer. He was, I think, the first one treated being paid for by Badger Care. She never knew about the total diagnosis. Because of the lack of sober home beds and so on and so forth, she brought him home, and that's where he died. HIPAA prevented the necessary information. So we need the professionals to please talk about and advocate to legislators a change in HIPAA because it's costing a huge, huge fortune.
Thank you so much. Next question, please. Thank you.
Good morning. A number of my clients start their path to addiction from sports injuries that they receive in high school. And then that leads to oxycodone particularly. And then when they can no longer afford that, then they go to heroin. So my question is, and it kind of dovetails Wanda's question, it kind of goes to Wanda's question, is there any research that is being conducted now that is looking at accelerating the shelf life of the opiates? In essence, as opposed to lasting a year, it may last 30 days or 2 weeks, which could eliminate the potency of the drugs. Yeah, that the actual potency of the drug would expire in a very, very short period of time.
Great question.
So the expiration dates on drugs are actually really arbitrary. So, and I know this, we deal with snake bites at the Poison Center. And so the medication that we use to reverse some of the bad effects from like a rattlesnake bite, they've been expired for 10 years. And so they've been doing testing on the potency for those drugs, and they're still totally fine. So, and I'll tell you this, but I went into my mom's medicine cabinet maybe like a year ago, and she had stuff from like 2004 in there. And so even if they are expired, people don't always look at the expirations on those drugs. And even if they do expire, they don't always, people still use them or dispense of it appropriately. Yeah. So they can say that. They can say that. They are not doing that. And like I said, the limits that they set, and this came up with the EpiPens recently too, because they tripled the price of those, and saying that they expired after a year. They don't actually expire. They just put those like limits on them. So yes, they can. No, they aren't doing that. Yeah.
Maybe we should make that
Thank you.
Hi, I'm Milwaukee County Circuit Court Judge, and I just want to provide a little bit of perspective on the legal justice side of opiate addiction. And so it's a comment, not for the panel so much, but I spent a year on the misdemeanor court. And so one of the types of cases that we see are retail theft cases. These are people shoplifting from Walmart, Boston store, whatever. And as these people come through my courtroom, I had about 400 cases over the course of that year. I would estimate that 380 to 390 of those, so virtually every single case of retail theft that came before me was an opiate addict. And some of them had multiple cases. And the reason I'm telling you this is as you go out into the community and begin to advocate, a huge problem we have is beds and treatment, inpatient treatment, and then we're talking about money. So if we're talking about money, you have to explain to people why it is important in our community. And it is deaths. I mean, obviously we don't want anyone dying, but what I see is people who are getting involved in crime who wouldn't otherwise be. So we have all of law enforcement. We have the losses from businesses that are having people shoplifting. And then we also have all the related family costs. CPS, Child Protective Services, gets involved when the parents are highly addicted, and I saw all of that in my court. So there is a huge, huge cost in the criminal justice system, in the child welfare system, and just really in business in general. And so when you start talking about the cost, think about all of those when you advocate people for dollars being spent for treatment, because it is huge and it affects a lot of different areas of society, not just the person being able to go out and work.
Thank you so much for that information, John. Okay, let's ask the question first. Okay.
Hi, my name is Carol D. Rodriguez. I am Puerto Rican. I live in the South Side. I also a student from Dr. Malone's class, Intro to Criminology. And I have a question. First, what has been done for families of single mothers for them to learn, actually, because usually single mothers nowadays are really young, and they really don't know how to cope with these situations and how to raise their kids through, a nice and good habits nowadays. And what is being done about it? Well, my comment about it is like, right now we have UMOs, we have a lot of resources out there to help them financially. But what is being done to help them in teaching them how to raise their kids? Because they really don't know. I have two daughters of my own. One is 18 years old, another is 14 years old. My oldest daughter just started working on a seasonal job. Why? Because I want her to go to school first. And unless she didn't enroll in school, I was not gonna let her go to work. Why? Because out there is it's awful out there, and you don't know how peers are gonna do, with your kids, actually. So I urge you, everyone that's here, to encourage young women, to try to run by the safe side. It's not about not having sex. It's about, protecting yourself. It's not about not going to work, but it's thinking of school first. It's not about you have a child and right now you don't know what to do. Look for resources. Is there resources out there to help you get a job in a stable shift, that when you come out of your job, you can be there with your kid? For when you come out of school, you can be there with your kid and teaching them the right values for these kids not to, go out there and do whatever. Thank you
so much. Thank you so much. Thank you. And I'm sure that's the cry of a lot of single parents, that we want resources to help to educate our children so that they don't get hooked on opioids and we don't have the crises that you all experience, and that the teachers do know how to manage our kids and have information available to them, because I believe they care. A lot of things happen because we just don't have the right information. Let's give a wonderful applause to our panelists this morning. Thank you, Dr. Stokes. Thank you, Dr. Okia. Thank you, Dr. Theobald. Thank you, Shea. Thank you, Rachael. Thank you all so much for being here with us. Oh, he has a question. I thought he was standing to take it. Okay. Okay, our chairman has a question.
Thank you. Thank you. If I would be presumptuous, I would try to ask two questions. One would be, what is the relationship between the pharmaceutical industry, the American Medical Association, and medical schools? If I were to bend the rules, I would ask that as my first question, but not being of that nature, I'll ask my real question. It was said that these drugs, opioids, have an effect on the brain. And I'm wondering, is that as to both parents, each parent, or just one, maybe just the mom, I don't know. And is that effect different than the opiate effect? And furthermore, do these other various drugs like marijuana, cocaine, alcohol, they also have an effect on the children of these users? That is, do the children inherit differences in their brain as a consequence of a parent or both parents using any of these drugs that we have listed? That would be my second question, if I were presumed to ask two.
Who would like to answer those two questions? Or one? Each take one? Okay.
I'll answer the other one.
Okay.
So the study that I found where it was looking at adolescent, it was in mice, but they were looking at the adolescent mothers. So this was passed through the mother's activity, not through the father. I'm sorry? Okay. Yeah, so that one, but again, it's animal studies, but they're correlating that with human, because there's no way to really study these effects in humans other than MRI and those types of, because they're invasive. They are actually looking at the brains of these mice. But that was passed through the maternal side.
And we see this in terms of lead poisoning. We call it epigenetics. So the way that your genome interacts with the environment and the changes that are made can be passed down to children. And it can happen through the mother or the father, because they each contribute the same amount of DNA. Now, the proportion, like whether it's mostly the moms or mostly the dads, depends. But it's true for all of them, all of the stuff that you talked about too. Now, in terms of how the pharmaceutical companies interact with physicians and medical schools and the AMA, it's a mess. So they tried to fix it. I think maybe 10 or 15 years ago, they said that pharmaceutical representatives couldn't go to physicians' offices anymore. They couldn't take them out to steak dinners or go golfing with them and give them all these like prizes and drinks and fun stuff. So now what they do is they show up and they just give you like free samples and a little pamphlet of their information, and they turn around and walk out. But that works still, right? Because if you're getting messaged that, oh, here's a new drug, it's not that bad, here's our information pamphlet, like your education on that new drug is coming straight from the pharmaceutical company. So that's not okay. And what they've done now, because they can't directly market to physicians anymore, is they do it to the consumer. And so patients are showing up, well, I saw this medication on the TV, I want to take that now. And people and you have a limited time with your patient when you're with them. And so to provide all the education why that may not be the best drug for their condition or for them with interactions with other medications, you don't always have the time to do that counseling. And some doctors aren't that straightforward. And then, like Dr. Stokes commented on earlier, is that you worry that you're going to get a bad review from that patient. The doctor didn't take my pain seriously. They minimized all my complaints, and then we get bad reviews or ratings, and then that is tied to our salary sometimes at different places, which is not. I wholeheartly disagree with that, because they've actually done studies where they looked at if a patient thinks their doctor is doing a good job, then they have actually a higher mortality and a higher rate of getting admitted to the hospital than doctors who may be a little bit more tough on their patients than others. 5
stars versus 2, so 2 is better.
2's better, right? Less is more. So it's a mess, because medicine has turned into a business when it shouldn't be. Absolutely, it should not be. And we're one of the richest countries in the world, and we have the worst infant mortality rate. We're in top 10, right? And so I don't know who agrees with this, and this is totally off base, but I think we should go to a single payer system where nobody has to worry about it and everybody has health care, right? Because the people who have the hardest time getting resources are the lower income, the minority groups, and they are just left behind. And I see them every day in the emergency room. I worked at Cook County in Chicago before I came up here, and I saw people that have been left behind by the system time and time again, and they come in way later in their disease state than they ever should have been, because they didn't have access to doctors or medicines. And so, sorry, I got sidetracked again. I gotta stop doing this. Okay, so here.
So I'm just going to piggyback on that, because I had one question from the woman back at the table over there. I'm going to answer your question now, I promise. Anytime. But it also very much has to do with what you were saying about access. So what you were wondering about was the intersection of heroin use or injection drug use, sex work, and HIV/AIDS, which actually we haven't touched on at all, because there's so many topics in this that we can only do so much in 2 hours. Very, very informative 2 hours. So essentially what we're seeing is that when you have a lot of intersectoral problems, right? So sometimes you're going to have people who are just using, and that's really what we need to address, but a lot of times with people who are also engaging in things like sex work, maybe they're being trafficked, maybe they're victims of domestic violence. One of the side effects that we do see is an increased rate of infection with HIV/AIDS. And we don't talk about that anymore. We don't talk about it anymore. We talk about opioid overdoses, we talk about hepatitis C, other STDs or STIs, but the HIV/AIDS part of this, it's not about the sharing needles, it's about the sex work part. It's about sexually transmitted HIV. So there's a really important component here that when you're talking to somebody who's actively using, you might not necessarily know if they're engaging or if they have engaged in the past in sex work, but this is why testing and linkage to care is such an entirely important part of this, because if you don't get tested and it's not provided to you in a way that you can access, you were just talking about this access. I have the incredible blessing and luck to get tested yearly via my primary care physician, because I go for my physicals most of the time. But there's a lot of people that are not going to have that access. So providing access to contraception or providing access to testing or to information about transmission, the heroin part and the sex worker part are oftentimes very, very intertwined. And a lot of people, 1 in 8 people don't know that they have HIV. Right? And in Milwaukee County accounts for roughly 50% of the new infections every year, because it's an urban area. There is a lot of people here who do not know. And when you have that kind of thing where it's drug use and it's sex work, and it might also include homelessness, we don't really know, it's a really big issue that coming at it from the other way is where we kind of need to be. Going at it when this person is saying, hey, this is my problem, this is what I need, that's where we have to be. Is helping them on that front line, that first primary thing, knowing your health, being safe, getting the care you need.
Thank you. Let's give our panel a hand again. They've been absolutely phenomenal. And at this time, I'm going to turn it over to our chairman of our Community Brainstorm Executive Board, and we're going to hear from him at this time, and he'll close us out with everything. Thank you so much for being here this morning.
Thank you, Sister Millie. Thank you very much. You've done a fine job. That was her first time. Let's give her another round of applause. I told her to call me if she had any questions. She had no questions and did not call. So she did a good job. And I really thank the panel. You have withstood our questions and answered them thoroughly, completely. And we appreciate your time, your experience, your knowledge. Thank you for coming.
An MCM production.